Okay.
Right.
All right. You bet. So I think we're thinking about learning in complex systems. And the two things I'm going to talk about is the components of a learning system. And secondly, a community-based learning system. Now, when we think about these improvements, we think about how we set up a learning system. And I'll mostly be speaking in QI language at this point in time. When we set up a learning system, we're thinking about what are the system level measures? How do we use system level measures to understand what's going on? These are a small set of measures that are what we call big dots that we plot over time. Secondly, how do we segment the population? Obviously, thirdly, what is our theory for change? The second part of setting up a learning system is the PDSA cycle, sequential testing over a wide range of conditions, learning by doing, using comparison groups, learning from one individual case and understanding what that looks like for the population. And finally, the third part is really how we scale and spread. And we generally use 5x scale so that we can learn fast and understand what works. Sometimes if we're doing N of 1 trials, we could learn something small, but when we use the whole scale, we learn what will work and not. This is the design of the learning system that we've been using for a number of years. I'll say now for about 12 to 13 years. And this is what it looks like in a clinical learning system. Patients and families and clinicians come together. There's kind of a point of care engine where the learning happens. We link the electronic medical record and biochemical specimens to the patient data so we can understand segmentation. We usually build a registry so we know who are all the people we're taking care of. And we begin to standardize care, which is QI, reduce the variability in care, and then begin to customize for the individual patient needs. And so when we do that, we can begin to improve patient outcomes in a pretty significant way because we are in fact identifying the gaps in care. And as we do that, we can link it to research and understanding. We can generate new knowledge. So that is a learning health system. And now we have to think about how we apply this concept of a learning health system that has improvement and research integrated into it, into the work. Now, second thing we're thinking about is what are the components of whole system transformation? And I'll skip these slides and send these to you so you can have them. But just so you have a feel that we're a large academic organization, with not as many beds as you probably have in your big institutions, but we have a very significant component of research. I think the third thing to think about is really the guiding principles and theories for change. When we're thinking about radical change in how we work, how we change our assumptions, and how we actually switch corporate philosophy. So that's how we think about theories for change. And you can see this capability building for improvement is key because without deep capacity and capability, even though you might have a theory of how you work, the likelihood that you can get those results are not very, very good. So I think we then go to thinking about system level measures that we use. This is an example of our early work on system level measures for a healthcare delivery system. So we're looking here at access and flow, patient experience, clinical outcome, and safety as well. We also use this model of the IHI's model of execution framework. How do we manage day-to-day improvement, local improvement day-to-day? I am in one clinic, I am in one nursery, I am in one inpatient unit with 12 patients. How do I improve it? How do I develop the resources necessary? And then how do I take that up to scale to achieve big strategic goals? So an example might be a bloodstream infection reduction in the ICU versus a bloodstream infection reduction across all ICUs, clinical units, home visits, and so on. Now we use the model for improvement that many of you are probably very familiar with. This is Nolan and Langley's work. What are we trying to accomplish? How will we know a change is an improvement? And what changes can we make that's an improvement? To move systems, we have to get very skilled at doing this. And we have to be able to run these PDSA cycles, simple plan, do, study, act cycles that are done over a series of time as we get to learn more and more, starting originally with hunches and theories and then getting to best practices to get breakthrough results. And then we also design our experiments, these experiments that we run of PDSA cycles in a manner in which we can learn from subsets of population. This is Deming's work and Ron Fisher's work, really in the fields where we might take different components. And in our case, we might take one unit and do something, not do it to the other unit, or one clinic and not another clinic to understand what works. Now, it's very important. The role of prediction is very important in improvement, because when I'm predicting what I think is going to happen, I am building my theory. And so a lot of time people worry about significance, but it's really in improvement, it's really the prediction that matters. And finally, we think about scale. So we start small, do these little experiments. We think about scale. And generally when we think about scale, so I might start in one clinic and now I'm working across every clinic in Bombay. I begin to ask myself, how do I learn? And you can see on the slide that when we're small, we're just thinking about services. But when we get big, we have to really design and think about whole systems. And so we build our QI charts, our measures of success, as you can see on this left slide. And then on the right side of the slide, you can see our PDSAs that we run over time, eventually getting into multifactorial work. Now, fundamental to improving systems is understanding improvement capability. We think about improvement capability as capacity and capability. And what I mean by that is capacity is an individual's ability to improve the system, but the capacity is the system's ability to transform change. And we believe that our success at Cincinnati Children's and the work I show you depends on the capacity and capability to be deep, multidisciplinary, and we think about scale, always think about scale from the beginning. This is how we train our folks in improvement. We train broad and deep. We expect our senior leaders to be improvement experts, because when they are coaching and when they're listening to the leaders in the organization, our standards are very high for who get trained. We expect the training, everybody to do 100% of the training. We expect everybody to do a project with the training, and we've been very successful in doing that. Another important part of our work is really around prediction. When we're improving systems in the hospital, this is the NICU parents and guardians telling us every day how well they did today, or how well they felt, or did they feel supported. And you can use simple measures like the number of red things in that bowl versus yellow things to understand how well the day went. So sometimes we have to be very quantitative, but sometimes we can be fairly qualitative. The role of prediction, mitigation, escalation is important. I don't know how well you sustain it in the organization, but we use a series of huddles as a mechanism for us to sustain this. So who do we think is going to get sick? What are we going to do to mitigate that sick person? How are we going to escalate to solve the problem? This is what a hospital-wide system looks like that we designed at Cincinnati Children's, and that we now use across all children's hospitals across the United States. We begin with these predictions of who's sick, who might get sicker. We run a series of huddles. You can see here the ICU huddles, the emergency department huddles, the OR huddles, and individual inpatient unit huddles. These huddles then become an institution-wide bed huddle that allows us to manage our capacity. So we've shifted from kind of one-off conversations to really running our system like the military does. And we actually learned this from the aircraft carriers in the Navy, who we visited to learn this, to an institutional huddle, to an institution-wide safety call. These huddles happen 24 hours a day. So we start in the morning at 6 a.m. with a small huddle, and we end at 1 a.m. the next morning with the next huddle, allowing us to keep track of everything that's going on. And when we do this kind of huddle, which has got an identification and mitigation, we are able to say, these are the 5 kids I'm worried about today, or these are the 20 kids that I think are at risk, or here's the 50 kids that I think are going to be delayed in their surgery. We are able then to create a system, a high reliability system, as we call it, very similar to aircraft carriers and planes. And this is a days between chart of serious safety events where a patient is harmed and there is an alteration in pattern of care. And you can see here that every 20 days, when we started in 2006, we had a serious safety event. We are now gone a year without a serious safety event, sometimes 2 years without a serious safety event. So you get a sense this is a chart of a days between chart, not a regular usual run chart. So you'll see that we are now going into years without a serious safety event, built on that series of huddles and built on flattening the curve so that the individual nurse at the bedside can in fact identify and escalate a problem. When we shift from the hospital to thinking about clinical outcomes in the community, using this learning health system model of patients and families engaged with clinicians, standardizing processes, reducing variability, identifying gaps in care, and generating new knowledge, we begin to look at something like this. So this is an inflammatory bowel disease work that we did. We begin with identification and stratification. We begin with encounters. We begin activating self-management for the patients and families. We want to be sure we're delivering the evidence reliably. And when we build what we call reagent grade models, meaning not so much variation that I can't tell the signal from the noise, but very narrow variation, I can begin to identify and begin to understand segmentation of populations. And so when we do that, this is the Improved Care Now network, a network across now, I think, many continents to specifically look at children with inflammatory bowel disease. We can begin to understand what that looks like and begin to share that knowledge so that everybody can learn faster. And when we are able to do that, we can link that back to basic science, advancing biologic therapies. And here's a graph of sustained remission in inflammatory bowel disease over time. Again, you can see how the control chart looks, how narrow the control chart variation gets, and how we get up to high rates of remission. And when we do this across multiple conditions, this is a network of networks. We're looking at patients with remission in inflammatory bowel disease now up to about 80%, reduction in maternal mortality and maternal risk in hospitals on the right-hand side, mortality related to cardiac surgery, and serious safety events, this network across the world that we have, you can begin to see that we not only save thousands and thousands of children risk, but we also improve outcomes. And now we have this network of all of the children's hospitals that begin to work together, begin with a huddle on a daily basis that tells us how fast people are learning. So you can see that in healthcare, we think about these kinds of things for transforming systems: reliability science, which we learn from aircraft carriers, network science, how we run a network, the science of scale, but then also, very importantly, trust and transparency and how we get people to engage with us. What does leadership behaviors look like that builds this kind of success? How do we build cooperation among people who might compete with each other? How do we build a movement? So on the right-hand side, it's all social science. On the left-hand side of your slide, it's all about hard reliability science. And a very important piece of change, of course, is Everett Rogers' work on diffusion of innovation, where we move from thinking about who will adopt the process early to the most traditional people who are the last people to join. And we know that if we build it systematically with the science, that we can transform industries. Now, of course, there's always challenges. There are people that don't agree with what you're thinking. This is a quote from Niccolo Machiavelli that talks about how the creation of a new system is difficult. So you can't be naive that just because you're a leader or just because you're a good person that you're able to build the system. There's a scientific method to doing that. I want to shift from the hospital to the community to think about a community health learning system, since there we're not thinking only about the ICU or only about a single inpatient unit, but we're thinking very broadly. This is the Robert Wood Johnson Foundation's theory around health. So we've shifted from thinking about healthcare to thinking about health. And obviously here thinking about social inequities, we're thinking about this medical care, which, as you can see, is a very small contributor to total health. It's where we live, it's our communities and homes, what are our working conditions, how do we all behave personally. And so I want to shift from thinking about healthcare to health. This is neighborhood near Cincinnati, near my house where I live, near the hospital, but I get closer to the neighborhood, this is what it might look like. And many neighborhoods in the United States, similar to neighborhoods across the world, are segmented by poverty, segmented by different groups of people. The houses are boarded up. In order to understand how we might actually move from healthcare to health, we use this design thinking approach. This, of course, is how new products are developed across the world. We start with a theory of what's happening. This is a little boy called Daryl who has persistent asthma. You can see his story. He takes a lot of medications. He's had ED visits. He's been in the ICU. But on the right-hand side is really the story of Daryl. He lives with his mother and siblings. He relocated because of a fire. He spends his weekends with his dad and his dad's girlfriend. So he goes back and forth. He forgets to take his medication because he leaves it at another place. His apartment is dusty. And this then means that this social context, these factors that are in our social environment, whether you're in India or in the United States or in New Zealand, you can see that they have an impact on the health. In my case, I'm thinking about kids. This is building code violation density related to asthma visits and hospitalizations. And you can see that by neighborhoods in our city and in our county, you can see rates of hospitalizations seen here on the right-hand side in red, which is an incidence per 1,000 child years, and on the left-hand side in green, close to zero. And this is directly linked to income and poverty. And so health and function, social environment, physical environment, all are important. And I'm sure you see these complexities where you are as well, where children from the red neighborhood have all of these sequences: transportation, poverty, depressed parent, cockroaches that have a role in asthma, likely to have cracks, likely to have difficulty. Therefore, if we're interested in moving to health, we have to create a neighborhood network, not only the pediatric practice where the child might come periodically, but pharmacies that will deliver a medication, schools that understand how to take care of children with asthma, legal aid to prevent the family from being kicked out of the houses. And you can see by size of the font, housing remediation, that primary care practice is a very small contributor to health. And these are all the people that help us think about how we inform health. And when we do that, we can see reductions in hospitalizations as shown in this control chart for children with asthma by delivering point-of-care medications, home delivery to the pharmacy, redesigning the home, building these nursing partnerships in the schools, and improving public benefits. But unfortunately in Cincinnati, just like in one of your cities, not only do we have problems with asthma, but we really have problems with overall in this current state of health, not only of asthma, as you see in the top right-hand box, but kids not being able to learn at kindergarten, not be able to read by 3rd grade, hospitalized for psychiatric conditions, an ever increasing issue for us in the United States, and infant mortality. How do you deal with a system like that? And here I'm showing you the same neighborhoods I showed you before for that child with asthma. Now I'm showing it to you for these other areas: injury rates, asthma, preterm births, and 3rd grade reading. And you can see that based upon neighborhood where you live, and I, having grown up in India, I'm sure these look similar to you, depends on the outcome for children. So we have to move beyond healthcare clinics to really thinking about unemployment and how parents are overwhelmed. What about domestic violence? What about meeting basic needs, and begin to think about that? And that requires a different level of collaboration, which is hard to do. And we need to now build on collaboration across sectors in a city to be able to improve the health of children, not just thinking about the health sector, which consumes an enormous amount of resources with not necessarily sufficient outcomes as the answer. And now we begin to think about broader issues that I mentioned earlier about collaboration and relationships. With this in mind, we launched a learning network for the community, having done about 7 or 8 networks in our institution across the country. And we're here thinking about these measures of infant mortality, of disparities, that children will be in classroom, that they can learn by 3rd grade is the goal, so that the kids are ready to succeed, and that all kids are awesome readers. Now we shift from thinking about only about the healthcare concept to thinking about capacity and cooperation, and understand the power dynamics that are important. And in this work of thinking about this, definitely relationships are at the center of the work, as I've mentioned to you earlier. A lot of time people think about the technical aspects of improvement and quality improvement, but all quality improvement is actually a social context. So we understand the needs of each community. We identify the common threads. We form a learning community with a common purpose. This is defined by the goals we set. We design a data system that allows for continuous learning. And then we envision what all the stakeholders in the system want. And so these common aims, every child in Ohio, the state I live in, will have optimal emotional and behavioral health. In the schools, we're looking at lost instructional time that is lost for the kids to learn. We're looking in primary care as how the kids are doing with their health and health care. And we begin to work with parents and families in communities. The measurements, once they're identified, we use these measures just like in every quality improvement to think about it, except some of these measures are in the community. We try to take the data from the community to make the measures easy to understand. And then we build this capacity for improvement, as I previously said, capability and capacity for improvement that is multimodal, multidisciplinary, multi-sector. At this point now, we have probably about 10 ways in which we can build this improvement using what the context looks like that allows us to think about how we will build and scale. So here's an example of community QI capability building, which looks different from the hospital QI capability building, which we've been doing now for about 20 years. And so we're training schools in quality improvement, superintendents, children's home. We're thinking about the health department, the health commissioner, and everything that happens there. The urban league, this is where housing, this is where housing is offered to people. And we begin to understand what will it take for us to change outcomes for kids. In primary care, we start with the Thrive by 5 measure. This is the measures at age 5, are children fully vaccinated? So this looks a little different from the usual measures because we're also including speech in this measure, we're including literacy in this measure, and we're measuring social-emotional competence and emotional maturity for children to be able to thrive. So we're not only thinking about weight and hearing and vision, but we're also thinking about many other factors. The Thrive by 5 measure then includes immunizations, vision, dental, hearing, speech, behavioral health, BMI, body mass index, and emergent literacy. And we begin then to partner not only with the primary care in our place, but also the health department and all of the community partners, including agencies like Head Start, which is a very early place where children learn to read and learn to practice. And when we do that, we look at primary care-centered outcomes and community-centered outcomes. We look at visit-based outcomes, but we also look at these complex outcomes of literacy and body mass index. Obesity is a very big issue for us and in the United States, especially among African Americans and especially among poor people, because the nutritional food that they get through standard services is pretty unhealthy. We begin to think about gap closure. How will we find these kids at the population level, including vans and outreach that allow us to get to these kids? And when we do that, we can begin to look at the bundle of care, and we can look at the complement of bundles. So here you can see immunization, dental, vision, hearing, BMI, communication, speech and language, literacy, and social-emotional learning. And in each case, how well are we doing? You can see that in some cases, like immunizations, we do pretty well. In some cases, like literacy, which is not focused purely in the scope of healthcare, we might do worse. So we begin to think about how we close these gaps. And then we have to catch up if we're not able to do it in order to have kids be ready for school. This is the control chart at the visit-based level. So we're now close to 100%. If you come to the visit, do you get everything that's necessary? But of course, we're very interested in the people that don't visit and how we could do that. And we begin to look, for instance, here is ASQ, which is a measure of ages, stages and questionnaire. How are you doing? And you can see in some cases, we still have variation and a ways to go. We also reach into the Children's Hospital for kids that are admitted, where we can close their care gaps. It's not a very large number, but it's significant so that we could do that. And we also try to get our kids enrolled in preschools so that they can, in high quality preschools, so they could learn. We now scale this across the health department, across the city, to all of the clinics in the city and in the Cincinnati Health Department. The next area I want to talk about is mental health prevention in primary care. We look at children that are seen by psychologists or seen in primary care and have problems with behavior. We begin to think about how we will intervene in all of these cases by coaching parents, sometimes by home visiting, sometimes by working directly with the kids. We begin to notice that many of our mothers, partly because of poverty, partly because of loneliness, often have depression. And of course, if the mothers are depressed, their ability to work and react with a child is poor. And when that happens, there's depression. This may not be an issue in India, but in the US, it's a very significant issue. And we do that, then we begin to build these community relationships so that in schools, and in various agencies where the parents go for food or for shelter, that there are ways in which they can teach and learn, and we begin to impact the kids in that way. We also begin to reduce disruption in the classrooms, begin to put back what we call lost instructional time, allowing us to be able to reduce these here, as you can see in this run chart, and allowing us then to build learning in the schools. From there, we're now building a cross-sector network. Here's the mental health work in the schools. Here's the mental health work in the community. Here's the mental health work in the pediatric clinic setting, allowing us then to really uniformly across the city build a method for building that. We also design around children, families. Here's some work on reducing infant mortality. Here, by basically using our design work, we understood that small number of women made a difference to the whole community, that the ability of the community to support the woman in her work was important. And we began to build these partnerships in the community and in the neighborhood. And we moved from reducing preterm births, which happened early on, as seen on this slide, by each neighborhood, now to really beginning to think about how would we intervene in this case? And in many of our people who have this, they are single mothers, mostly African-American. We began to build this concept of social connections and neighborhood feasts and mothers working together along with personal contingency and support. We knew we had to perfect the system, but the system had to be absolutely perfect for us to reduce prematurity, because prematurity is related a lot to stress. We had to activate the community to support the women, and we had to customize for each mom. And in that case, using the hospitals and the systems that we work with in the primary care clinics, along with the community health workers that visit the homes in Every Child Succeeds, a program that also does home visiting, addressing housing solutions, partner violence, where women are subjected to violence, public benefits and mental health service. We build a collaborative, an improvement collaborative across the community, across all of the hospitals in the community, the home visits and the nursing homes. And we were able to show and sustain significant reduction. This is preterm births, less than 28 weeks, in the controlled neighborhoods compared to the comparative neighborhoods. And we were able to show this. And we're now in the process of scaling this work. And we have found a significant reduction in mortality, infant mortality. This is early data from this one neighborhood, and I'm just showing you the neighborhood with the same data now sustained up into 2020. Obviously, hospital costs are vastly reduced if you're able to reduce prematurity, the number one issue for costs in early childhood, and we can scale to neighborhoods. We're now thinking more about mental health and reduction in hospital bed days. And this term bed days is a term that's locally used here. This means, am I spending my time in the hospital or am I spending my time at home? This is a single neighborhood, again, showing you a comparison for that neighborhood from before when we started to where we've reduced the bed days, allowing us then to be able to scale this across multiple divisions. And so as we think about these factors of kids not reading, kids not being able to go to school, children's immunizations not being good, we begin to partner across the sector with people from the Cincinnati Public Schools. So this is the entire school district. Our goals here are academic outcomes, kindergarten readiness, literacy, and math, high school experience of the student and the teachers and the parents, how well we're managing the system, operational efficiency, safety, building violations, and then how we build the supports that the kids need. Early PDSAs, as you can see here, put up by the children on how they're learning how to read, a plus delta, which is what we use in improvement, what worked, what didn't work, what do we need to change, beginning to engage children in this work, data visible in the classrooms. Here's a third grade map, which is the reading score, and you can see how the children post themselves over time. Here's schools that hit the QI schools that hit the mark, the non-QI schools that don't. So here you see the QI schools, here you see the non-QI schools where the mark is not hit. And we can begin then to understand and think about how we improve outcomes. And when we do that, here's where we were when we started. This is the Cincinnati Public Schools at 46. This is third grade proficiency rates improved up to 70 now, comparison of other school districts in the state. And we can begin to see improvements in gaps that the kids have, allowing them to learn. This kind of a broad context of systems across, this requires social workers and neighborhoods and parents and teachers and principals to be able to work together to fix the housing. And we're now building this capability across the entire district, scaling then across to 5 full schools next year, but we've scaled the literacy work across all schools and they're sustainable. Now we are now moving towards a mental health learning network model where we're co-producing health with parents. Here's an example of an Avondale family. This is the neighborhood that the hospital is in. And we call this a snowflake model where we start with a small group that connect to other people, that allow us to be able to build the ability of parents to read to kids. And you can see the differences in how the parents have learned how to read to their children, understanding their role in helping their child succeed. These are the grandmothers in the neighborhood that are working with these parents to help the support. We're also working on health law partnerships to allow for the families to meet the needs to be able to stay in the place they work, empowering residents and building justice promoter services, helping families stay in the neighborhood, stay in their houses so that they are not evicted, understanding pathways of eviction, and bringing in all of our partners to think about this, from healthcare partners like TriHealth and Cincinnati Children's and the Cincinnati Health Department, to neighborhood partners, to Cradle Cincinnati, which is in the homes, to other hospital settings, to the metropolitan housing where houses are fixed, building this model. So what will it take to transform the system? The first, I think, is learning to see. The second is agreeing to act. The third is acting to learn. The fourth is using improvement science, creating capacity, thinking beyond boundaries, not just thinking about the clinic when the person visits and doing it well, but getting into the community. And then having optimism and building this cooperation across the system that makes it work. I will stop there and take any questions that you might have. This is a classroom in which a teacher, if I run you this tape, which I'll send to you, the teacher is actually asking the kids how they could improve it. And the kids are giving that child feedback.
And now it's time for her compliments. So we're going to do her compliments.
So they're giving her a compliment.
And then we will pick our Roar's helper for next time. All right, so Miss Pitts.
Okay, so I will stop there and take any questions that you might have. Are you there?